My name is Jalal Samhoon. I am a Florida Atlantic University internal medicine resident, and I will be discussing a rare case of small cell esophageal carcinoma. Small cell carcinoma of the esophagus is a very rare and highly aggressive malignancy that consists of less than 1% of all esophageal cancers, the majority of which consists of adenocarcinoma and squamous cell carcinoma. I will discuss the clinical presentation, diagnostic workup, and management of a patient who is newly diagnosed with small cell esophageal carcinoma. A 69-year-old male presented to our hospital with progressive weight loss and dysphagia. Ultimately, his CT chest revealed a 6.4 by 5.8 by 7.1 centimeter lower esophageal mass with lymphadenopathy. Endoscopic evaluation revealed high-grade esophageal stricturing as shown in image 1A and an esophageal mass as evident in image 1B and C. Contrast during the endoscopic procedure demonstrated stricturing as evident in image 2A, where contrast is not able to freely flow into the stomach prior to stent placement and able to then freely flow into the stomach as evident in image 2B. Biopsies during the endoscopic procedure were obtained via the help of endoscopic ultrasound of the esophageal mass. At the level of the esophageal stricture, fluoroscopic Savary wire-guided esophageal balloon dilation was performed to 12 millimeters and an esophageal stent was placed as shown in image 1D. Direct visualization of the stomach and duodenum were grossly unremarkable. At this time, the patient had been medically optimized and stable for hospital discharge with instructions to follow up with hematology oncology, and ultimately he received a CT PET scan that revealed markedly FDG-avid gastroesophageal masses extending into the gastric fundus and an FDG-avid upper abdominal lymphadenopathy without any evidence of distal metastases as evident in image 2C. Ultimately, the patient received induction chemotherapy and has been receiving radiochemotherapy without any major complications. The risk factors, clinical features, diagnostic workup, and prognostic factors, as well as the management for small cell esophageal carcinoma, are unfortunately limited due to the scarce number of cases in the available literature. However, what we do understand from the number of small cell esophageal carcinoma cases is that risk factors include alcohol, smoking, gastroesophageal reflux disease, Barrett's esophagus, thermal injury, and foods containing nitrosamines. The clinical features do not differ widely from other esophageal malignancies and consist of dysphagia, primarily to foods more than liquids, especially early on in the disease, weight loss, poor appetite, and chest pain. The initial diagnostic workup would consist of a chest x-ray with a CT scan of the chest and possibly an esophagram, but ultimately any patient with a suspected esophageal mass would require endoscopic evaluation with EGD and endoscopic ultrasound to have a biopsy obtained. The prognostic factors include tumor size, lymph node involvement, chemotherapy cycles, and the response to chemotherapy. Regarding the management, it is typically divided into extensive disease that has spread and localized disease which has not spread. In extensive disease, patients are typically offered chemotherapy or chemotherapy with radiation without offering surgical resection because surgical resection is non-curative. In localized disease that has not spread, patients are typically offered the same treatment options as those in the extensive disease, but they are offered surgery in cases where there is no evidence of distal spread. In terms of the chemotherapy options, it's divided into three main categories, primarily consisting of either a platinum agent, such as carboplatin or cisplatin with etoposide, FOLFOX therapy, which consists of folinic acid, 5-FU, and oxaliptin, or FOLFIRINOX therapy, which consists of leucovorin, 5-FU, irinotecan, or oxaliptin. If there are specific gene mutations that can be obtained in individuals, then a targeted chemotherapy or immunotherapy may be offered in specific cases. Given the severity and poor prognosis of small cell esophageal carcinoma, early endoscopic evaluation and initiation of chemoradiotherapy is crucial. Unfortunately, the prognosis typically remains poor despite early initiation of treatment. Small cell esophageal carcinoma is associated with early dissemination, with initial symptoms noticed after the disease has already metastasized. Dysphagia due to esophageal narrowing from advanced tumor burden increases the risk for complications such as aspiration and failure to thrive. PEG-2 placement is indicated once patients are unable to tolerate oral intake. However, comparison studies have concluded that there is no increased aspiration risk in patients with esophageal stents on oral diets compared to nutrition via a PEG-2. This case highlights the presentation, evaluation, and management of a patient with a very rare form of esophageal carcinoma. Though esophageal stenting is not curative for occlusive esophageal malignancy, it does enhance patient quality of life by improving tolerability of oral intake without increasing the risk of aspiration. This case emphasizes the importance for researchers to continue investigating the pathogenesis, pathophysiologic mechanisms, clinical features, and management for small cell esophageal carcinoma in order to increase favorable outcomes and mitigate the risk for complications